This is PT Pro Talk, the podcast for physical therapists who want to improve their clinical skills and be more successful. I'm Mariana Parks, physical therapist and your host, and today I bring you my conversation with Dr.Jamey Gordon to discuss real-world application of movement and therapy. During our discussion, Dr. Gordon will talk about his experience serving on the medical staff of the USA baseball national team for 6 years, the most common injuries in baseball, using the movement system impairment to assess and treat patients and athletes, how to find the why of the problem and understand why each athlete moves the way they do, or experience pain in certain areas. Dr.Jamey Gordon is a physical therapist, certified athletic trainer, and certified strength and conditioning coach. He has worked with professional athletes in the MLB, NFL, NBA, and Olympic levels. If you find this conversation informative, I encourage you to subscribe to our channel, hit the notification bell for updates, give us a thumbs up, and share this episode with your colleagues in the clinical field who could benefit from our insights. Thank you for tuning in, and let's dive into the discussion. PT Pro Talk is only possible with the support of the forward-looking and innovative companies like Systems for PT, the Do Anything Anytime EMR. Systems for PT develops systems for clinicians so you can focus on your patients. Go to systemsforpt.com to schedule a demo today. Sarah Health, and here is a special offer from our listeners. Visit sarahhealth.com/PTProTalk for a 90-day free trial. That's sarahealth.com/PTProTalk. Make RTM simple. Choose Sarah Health. That's sarahealth.com/PTProTalk. Hi, Jamey. Welcome to PT Pro Talk. How are you today?
I'm great. Thank you.
Thank you for coming. And let's get started just talking a little bit about yourself and your career.
Okay. I graduated from Washington University School of Medicine PT program with a master's degree in 1997. That was when the entry level was a master's degree. Went back and did a post-professional doctorate from there and finished that in 2007. That was after they had all transitioned to an entry-level doctorate program. I'm also a certified athletic trainer, been doing that since 1995, and also a certified strength and conditioning specialist. And right now my clinical practice focuses on mostly athletic injuries, sports rehab, sports performance, biomechanical analysis, etc.
Okay, and I know that you work with the U.S. baseball national team, right? From 2008 to 2014?
Yeah, and my other previous job before I started my practice where I am now, I worked with a lot of Olympians, so track and field, swimming, diving, gymnastics.
That's awesome. Would you talk a little bit about your experience there? So you were the head athletic trainer.
Mm-hmm.
So how was your experience during that period?
Well, outside of being stuck in Mexico in a hurricane, it was really fun. The U.S. national team was a lot of fun because those kids were just coming up. So they were really young. They were 18 and under, and their high-level experience was just starting. So to see those kids at a young age, who are now a lot of them in the major leagues, kind of fun to watch them and see them as they come through the ranks. But it is also very interesting to see the level of competition that even young athletes can perform at. It's pretty impressive, both physically and mentally, and just skill wise. It's really impressive.
And what was your role? So you were not as a physical therapist there?
Not formally as a physical therapist. I was there basically to help them get ready for games. So help them with warm-ups, etc. Address any injuries that would come up during competition, address any injuries that they had coming in to competition, make sure they're just generally healthy. If someone got sick, we would take care of whatever it was that they needed to have. And then obviously if they had any kind of emergent kind of conditions, injuries, etc., we would take care of the emergency kind of stuff and be there just as a health advocate and to take care of that kind of thing. And then a lot of the time it was spent just keeping people healthy. When the pitchers were done, we would make sure that they recovered well and had the physical means to recover and be ready for their next pitching outing, etc.
And like to do that, would you use more your PT skills or more like athletic trainer skills? What would you say?
Probably more athletic training and strength conditioning at that point. We didn't really have any really bad injuries that needed what we would call like a formal physical therapy. But my mindset is always kind of looking at movement in the way that I learned in physical therapy school versus athletic training. So kind of a mixture of both, but from the technical standpoint, it was more athletic training.
Mm-hmm. But I'm sure that your view as a physical therapist also helped you in a
Yeah,
different way.
for sure.
Yeah, yeah. And then at that time, the team got a gold medal
Yep.
in 2014. What was the competition?
It was all Pan American teams. So Mexico, Cuba, Panama, Venezuela. I think that's all of them. So
That's
it
so
was a lot of
nice.
fun.
Yeah, how exciting. Um, and what would you say were the most common injuries in baseball?
When with the team, it's more muscle strains. So someone's tight, or they have a strain from running the bases or whatever. We didn't have any acute arm injuries during the competition, but the arm injury, the elbow, shoulder, those are the most common that we see in clinical practice with baseball players.
And then I know you have your history with the movement systems impairment, right?
Yep.
Um, so how do you use that to assess and treat your patients?
So movement systems impairment process is a little bit different than what a lot of people learn in either athletic training or physical therapy. The normal is to do various tests on different body parts and then try to put those pieces together to inform them about how or why someone moves the way they do. Whereas movement systems impairment looks at the movement first, and then that guides you to the testing to figure out why they're moving the way they are. So we kind of put a label or a description on how they're moving badly, if you will. And then that narrows our test down to, okay, well, there's only a handful of things that would cause that movement to be bad. So then we test those things. So it's almost like a backwards way of looking at a patient. We look at their movement first, pain or no pain, and then try to figure out why do they do that, as opposed to, oh, my shoulder hurts. So we test the shoulder and then spread out from there. So it's kind of a flip flop mental process in looking.
Yeah, would you walk us through like how would that look like in practical terms? So if you have a patient and they have, for example, elbow pain, so what would you do? Would you start asking them to move?
Yeah. So we'd look probably more at their shoulder first, to especially if it was a thrower, knowing that the shoulder's critical to proper elbow health. Elbows and knees are similar in that they, in and of themselves, they typically don't move that badly, but the other ends of their kinetic chain. So for an elbow, it's shoulder primarily because it's not on the ground. Uh, that next kinetic chain link is usually the problem. So for knees, ankles, ankle feet, and hips are usually the problem at the knee. For an elbow, the common problem with the thrower is at the shoulder. So we just start looking backwards at the shoulder. We look at their trunk movement. We look at their core strength, and then try to figure out if. And then we watch them throw, obviously, because that's if it's a thrower with an elbow issue, we would want to see them throw. So if we can find all the components of what would what goes into throwing. So a common thing would be we would look at shoulder range of motion, shoulder strength, scapular movement, thoracic rotation, core strength, hip mobility, balance on one leg, hip power. So we look at all those things and then we go watch them throw. And then if we see a deficiency or pain in their throw, we'll know where that came from. So if we detect that they have poor thoracic rotation in the exam and we watch them throw and they don't rotate well, but then we know that thoracic rotation was the cause of the overstress of the elbow and therefore causing the elbow to hurt. So and there's a system for that kind of investigation for all the regions of the body.
So like would you get started with like normal range of motion and then go through to the movement that they execute or vice
Yeah, I
versa?
mean, just cursorily, we would just, can you bend it all the way up? Can you straighten it all the way out? See if there's anything related to their acute injury. But really the fix of the problem is to fix the movement in total, not just the elbow range of motion. So we look at movement as full body movement, not just movement of an elbow or movement of a wrist or movement of a shoulder. It's the body's movement in space.
And like in your experience, would you see people, for example, with full range of motion on shoulder, and then when they're throwing, you see that they are not moving well, but it's not necessarily because of restriction on movement, like on the joint. So then in that case, for example, do you practice the movement? How do you go about that?
Yeah, it depends on what we find in the exam. So if their shoulder has good passive movement, but they don't have good active movement or strength, or in the case of throwing, they're not strong enough to decelerate or slow their arm down, then we would work on those kinds of things. We might work on strength or motor control or positioning within the range, like a 90-90 shoulder position or something like that. So we just, whatever we find in the exam, we start with that, even if it's not at the elbow. And then we teach them how to move better.
Mm-hmm. And how would, like, I know that depends on the assessment, but like on the movement system impairment, I remember of my conversation with Shirley, so I'm trying to put the pieces together because for her it seems very easy. So, so I remember her saying a lot about training the movement, right? What they do at home, the way they move, the way they do all the things, and they would practice that. So like on the treatment itself, I got that in my mind that is a lot about repeating the movement. Mm-hmm. But like putting that in a sports context. So you talk about strengthening and all the, like the other components that involve the rehab. So how would you combine that approach of the movement system impairment with the normal conventional PT rehab?
Well, the way I would describe normal PT rehab would be you have a lot of tools, and what MSI does is it tells you which tool to use. So if someone's poor movement is, let's say, in a hip because their hip doesn't rotate well, then we would use joint mobilizations, dry needling, soft tissue mobilization, whatever we need to do to make that hip move correctly so that it can move correctly. Not just range motion for the sake of range motion and then hope it turns out okay. We would then train the motion or train the movement for them to correct their issue. So the way I see what MSI is kind of your blueprint or the reason to use certain tools, and traditional PT is the skill at having all those tools. So if you were building a house and you wanted to put shingles on your roof with nails, you wouldn't use a screwdriver. Even though you have a screwdriver and a hammer, you just maybe not know which one to use. MSI tells you, use the hammer for the nail.
So it's like an assessment frame, like you have like a way of going through assessment to kind of guide your treatment. Correct. Based on that assessment that tells you a lot of different issues.
Yeah, and that's really if you look back at literature on what is a diagnosis, when you make a movement systems diagnosis, it should be good for communicating between professionals. So if you saw a patient and you said, they have hip medial rotation syndrome, I'd be like, okay, I know what that is. And I know the handful of things that could go wrong to create that problem. So communication, and then guiding treatment. So I know once I have that diagnosis, what are the things that could possibly be wrong that I have to address? So if you gave me a movement diagnosis for a patient, I would know, I'm going to just see what treatments she's been using because it's been far narrowed down at that point because of the diagnosis, and I'd have a really easy time handling that patient. The other thing is research, which is where we haven't really gotten to yet because everybody kind of has to be on the same page with the diagnosis system before you can reliably test it in a research setting. So are joint mobilizations really good for hip medial rotation syndrome? Well, you'd have to have enough people doing the diagnosis system to identify those patients and then to do the research on it. So that component of a diagnosis, we're not quite there yet, but the other two, it's super helpful with.
Mm-hmm. And have a way that everybody can communicate.
Mm-hmm.
Okay, so if we think about to become a little easier to understand, So let's talk about common injuries. And would you help us with practical examples of how would you go about common injuries on the shoulder or elbow to help us understand?
So shoulders and knees are pretty easy places to start when you think of movement issues and things that people are familiar with already. So if you were to have a shoulder and you have, let's say, a medical diagnosis of subacromial bursitis or tendonitis or impingement, something like that, the movement diagnosis is going to tell you why do they have that. So we're going to look at scapular rotation, anterior posterior tilt. So we're going to narrow that down to a scapular diagnosis. So very commonly they have an insufficient upward rotation issue with their shoulder blade or scapula. So it doesn't rotate up or doesn't posteriorly tilt enough, and then therefore you get impingement. So we're not changing the medical diagnosis, we're just applying a different kind of diagnosis. So then the treatment then is, well, let's get the shoulder blade to move better, whether that's a stiffness issue or a strength issue or motor control issue or just a habitual postural issue or whatever. We fix those components to make the subacromial pain, impingement, et cetera, go away. Now, we might also have things that we need to do to help heal that tendon. We might do dry needling, ultrasound, whatever for the supraspinatus tendon. But the end goal is to get the shoulder blade working better so that it doesn't impinge and therefore hurt. Same thing happens at the knee. There's a lot of great research out about addressing anterior knee pain with hip strengthening, and that falls right into a hip diagnosis. So if you had hip medial rotation with adduction syndrome, basically the femur rotates in and adducts, which then torques the front of the knee and creates knee pain. So again, we may do some things locally to the patellar tendon or patellofemoral joint to help that pain, but the real solution is to not move that way and make those corrections at the hip.
And I think that's a missing piece, I guess, because I think a lot of times clinicians are very focused on that body part without having this ability to visualize all the moving parts and be able to correct their mechanics, right? So, and with that approach, I would imagine you would see the numbers of recurrence decreasing.
Yeah, it really makes your treatments more efficient. So very commonly we see them for fewer visits, and you're right, they don't come back for other things. So our running population is really, really a good example of this. We might have someone who has a history of Achilles tendonitis, knee pain, hip pain, all just because they have one common movement problem or one common movement diagnosis. And once we fix that, all the other issues go away. So now they no longer have ankle pain or knee pain and hip pain all at once, or they chase it back and forth. They all go away. We see that also with neck and shoulder. We'll have people come in with neck and shoulder pain instead of neck and shoulder. We assess them all together. How is their posture? How is their movement? How's that connection between the scapula and the cervical spine and scapula and thoracic spine? What's that whole relationship? And once you know what you're looking for there, it's really pretty easy to detect and fix, and therefore efficient to treat. And then a lot of their other issues go away.
I guess they stop compensating all that chain that overloads, right?
Yeah, and that's a good point. Like the compensation patterns is really especially in the sports environment, that's our chief challenge, is to figure out why, if they're moving badly, is that a compensation or is that their true bad movement? So once we figure that out, then we can address all of them at the same time or individually or whatever we need to. But making sure that their bad movement, detecting whether that bad movement is a compensation for something else or is it the true movement problem. And with the movement systems impairment process, it's super easy.
And I was going to ask you, when you say bad movement, for example, it's not the more efficient way that they should be moving, right?
Right.
Some people develop different ways of moving, but would you say that it's not depending on each person? It's they should move in that way because it's more efficient. At some point, they're going to develop an injury.
Yeah, it's really the biomechanical ideal comparison. So if someone were to bend forward, touch their toes, they should move in their hips first and then in their lumbar spine late. And some people bend in their lumbar spine first instead of their hips first. So that would be an inefficient way to do it. It's common, but it doesn't make it right.
Mm-hmm. At some point down the road, it's going to cause some issues.
Yep.
And I would imagine that especially like in sports, having that mechanic right makes all the difference. Like you can have athletes performing in like high levels, right? If you're not correcting those issues early before they start developing injuries.
Yeah, and that's what the conversation we have with our athletes in an attempt to correct them is not only will their biomechanical efficiency help with their pain or injury or whatever they have, but it may make them perform better as well. So they may jump higher, throw harder, run faster, etc. And then the flip side of that is if they've been hurt, all the time that they're hurt, they're also not training to improve. So if we can get them better faster, they can resume their training faster and therefore improve and be ready for whatever competition that is that they have.
So it's just a constant way of assessing them. You're always looking for their mechanics. So you're either preventing injuries, improving their performance, or treating injuries.
Yep. We actually use the MSI system as a movement screen. So when athletes come in and they start training, we'll do this movement screen. That's basically a way to go through the whole body with some key indicators: hip strength, hip mobility, how they bend, how they squat, how they stand on one leg, how they single leg squat, their body position, core strength, etc. And then we'll know some of those key components, even if they don't have any pain. So they'll come in and do this movement screen, and we can tell, all right, of the building blocks of athletic movement, how do they perform? And if they have an inefficiency or something that's painful or something goes wrong, or then when we watch them move, like, oh, I can tell why you run that way because you have poor core strength, or you have stiff hip flexors, or you don't land on one foot very controlled. So that shows up in other areas.
Yeah. So then you can advise them on what are the things that they should be working to prevent injuries at that point.
Yep.
And then do you work like with their coaches or to make the connection?
Sometimes we do. A lot of our time is spent with one-on-one with athletes. So obviously they're the ones that have to know the most. But a lot of times if a kid has a coach that's open to us talking to them, we'll absolutely talk to coaches.
Okay. And I remember you were talking about the importance of the screenings, as you mentioned, the movement screenings. So you do that most specifically just with like athletes or with your normal PT population as well?
We can do it with the normal PT population. We don't necessarily, the more complicated movement that they're involved with, the more we have to search for movement problems in a wider range. So if we have a golfer, we'll go through the same movement screen because that movement's fairly complicated. Bend, twist, rotate, all that kind of stuff. If it's somebody who just has Achilles tendonitis from taking a walk, then we won't necessarily look at thoracic spine and shoulders and all that kind of thing. We'll basically just look at low back, hips, ankles, knees, feet.
And is that something that's common for your PT population? Or most people, because it's hard to sell prevention. So how, is that common? Is a service that people like look for? Or do you think like it's more really for athletes?
It's mostly for the athletic population, but similarly, the way that we commonly go to the dentist once or twice a year to see if we have a cavity, to me, everybody should do a movement screen at least once a year, just because we could more likely detect something way before it became a problem. The issue for us in the United States is most people have health insurance, and that health insurance doesn't want to pay for a visit when you don't have an issue.
Yeah. It would be nice.
It would
if that was the norm for everybody, right?
Mm-hmm.
Yeah, so it could prevent a lot of injuries, but I don't think people are too worried about it.
No, unfortunately not. We find that it's really, really important for the young athlete whose body changes a lot in the course of a year to get a movement screen done at least once a year, because they may grow 6 inches from one year to the next, and therefore when they grow 6 inches, their body moves massively different than it did the previous year. So that the developing athlete are the ones that are really, really important to check on a regular basis.
Yeah. And I was reading about you, and I saw that you're very much about finding the why, right? Why
Mm-hmm.
of the problem? What is the core issue?
Yep.
So, would you share with us what are the most common causes of issues that sometimes we PTs that don't have the movement, the MSI system formation, graduation? Like, what would be things that you would tell us that we could pay attention to, or things that are usually like the core of the issue that could help us with some tips?
I would always start looking from the middle out. So core strength, and not like your rectus abdominis strength, not how many sit-ups can they do, but how well can they create a rigid cylinder between the bottom of their ribs and the top of the pelvis while their arms and legs are moving fast or under resistance or whatever. So how well do they control the middle of their body? And then kind of each link in that kinetic chain out. So hip mobility, hip strength, scapular mobility, scapular strength, postural control. And then from there, you'll have a really good feel for how the rest of the body is going to move, or some possible deficits on why does an ankle pronate when they're running and land on one foot. Well, it's probably because their hip is weak or stiff, and then and along that next step is their core may be weak. So if we look there to fix the foot problem, that would be the first thing that I would look at, is look at the middle first and then go out from there, regardless of whether they're a foot injury or an elbow injury or whatever. So
That is very interesting. I remember Shirley showing me that spring that she
mm-hmm.
like, you're like one
Relative,
spring is
yep.
stiff, and that
Yep.
was like, oh my God, that blew my mind. I was like, I never thought about that way. So when you're talking about the muscle stiffness and how some things you have to, it's not like stretching or strengthening, but is also that I forgot the word that she used.
The relative strength, the relative mobility.
Yes. Yeah. So that was something that was new for me, at least, that I'm not familiar with all those terms, and like this different way of thinking about the body and their injury is so interesting.
A really good example of that is if someone had neck pain, like upper trap pain, and their shoulder blade sat too low, so scapular depression. The most common thing that people do for upper trap pain is try to stretch it. So they're trying to stretch, when really the solution is to keep it out of stretch and lift it and make the muscle stronger that lift the shoulder blade, or get a better postural habit, or when they're sitting at their desk, they're not letting their elbows hang down and putting that on stretch. So the solution, the common therapy solution, would be to stretch that muscle because it's sore. The MSI solution would be take the stretch off of it and shorten it because it's too long as it is.
Yes, very, very different, interesting. And then if people like want to learn more about the movement, the MSI, so I know you told me before that you were the instructor, right, for a while, I guess. I don't know if you still are. So how would that work?
Most of the instructional things come from continuing ed courses that either WashU does, and I think there's another group that is starting to do some continuing ed courses on it. I've done a few through PESI. It's a continuing ed company. But that's usually the way you would do it. And because I don't think there used to be a residency through WashU, but I don't think that really exists anymore. So just piecing it together through continuing ed courses. Typically a continuing ed course would be a couple of adjacent regions. So like hip and low back for one course, or hip and knee, or knee and ankle, or something like that, where you would group adjacent regions together. to teach the course. That way we're not trying to hit the entire body in the span of one continuing ed course or one weekend or something like that. It would be multiple sessions of courses to put all the pieces together.
Yeah. And yeah, to be able to connect everything, right? Because as you said, you have to make all these linking connections.
Yep.
Very interesting. Any other examples that you think are interesting about all these connections and things that before you doing MSI? I mean, I'm sure that everything changed, but anything that you want to share that you think it's interesting and different?
Well, I know it's not as much of an issue now, but sports hernias were a really big thing a few years ago. And what we were finding is a lot of athletes were doing what they would call core strengthening. They just were only working certain parts of their core. They weren't working their obliques to create that rigid cylinder. They were creating movement, which your lumbar spine isn't really built for any movement other than flexion and a little bit of extension, but they were doing all kinds of rotation, and they were basically overworking their rectus abdominis, which was then creating sports hernias in the attempt to keep themselves healthy. So basically the solution to that was revise your core strengthening program and train your body more how it's going to be used when you run, jump, dive, twist, whatever. And your rectus abdominis isn't as dominant for that as people were training it. The other is the issues that we're having recently with femoral acetabular impingement, which we see from the MSI perspective is a diagnosis called anterior glide syndrome. So there are factors both on the posterior side of the femur and the anterior that can either pull it forward or push it forward, but then it rubs on the anterior side of the acetabulum and then you get impingement. So instead of altering just the normal hip factors that PT would normally do, we work on the gliding things. So, do we need more joint space? Do we need a posterior glide? Do we need to stretch things that are creating it? But knowing that diagnosis guides that treatment. So we know, I have to check on this, this, and this. I need to look at posterior capsule. I need to look at iliopsoas strength or overactivity, and then rebalance all those things, because as that relative flexibility issue, as we talked about, with an anterior glide syndrome, you can be really stiff on the back and normal on the front, and you get anterior glide. You could be really stiff on the front, pulling the head of the femur forward and normal on the back, and you still get anterior glide. So it's just that relative nature, or it could be super stiff on the back and normal on the front, and you get you get anterior glide. So it's just knowing not just are they strong or stiff or short or whatever in the muscles, but how do they relate to the other parts of that system to create an issue. So analogy I use with patients is, if you are familiar with the big balloons that they use in the parades, like the huge Macy's balloons where they have all these people with cables that they hold onto the balloon. If one side lets off, the balloon tilts. If somebody pulls down too hard, but the other side is normal, the balloon tilts. So it's not necessarily a too little or too much. It's how it relates to the other side. So that's the part of the investigation, especially with joint mechanics, that we look at, is not just is one too much or one too little, but how do they interact with each other?
Yeah. And how would you look like a treatment on movement? So let's say you are correcting the issues that you find on the assessment, and then like, do you put together with them practicing the movement afterwards?
Typically, yeah. So if we have somebody who we have to do some sort of manual treatment or stretch or whatever, we would do that first and then make sure we train them on the movement. Even if they can't go through a full range of correct movement, we want to be really picky about how we let them move. So we don't let them fall into a compensation or fall into a bad or inefficient part of that movement. So if they can only go through 50% of a range well, we only let them go through 50%. And then the next time we try to get them to go a little bit more through good range or more efficient range of motion. So It's being very picky about what you let them what you let them do when you see them, not just do the exercise and hoping the exercise corrects it. It's making them move in the context of the exercise.
Mm-hmm. And then when they are practicing the sport, they have to be very careful and aware of how they should be moving, because you're not gonna be there with them, right? So you have to make
Right.
sure they're performing it in a way that's not gonna cause more issues.
Yeah, and that's really the challenging thing when we get to something that's really fast movements, like things in sports, or things that we don't want the athlete having to worry about thinking about. So, hitting a baseball, for instance, if the hitter is thinking about how they're moving, they'll never hit it because they need to be focused on the pitch and where it is and how fast it is and all that kind of thing. They don't have time to think about how they're moving. So we have to train them enough with enough repetition, enough correct that it becomes their normal. So we have to retrain their brain to work in a way that is normal, that they don't have to think about it. So kind of think of it as there's a continuum, that there's unconscious incompetence. So you don't know what you're doing and you're doing it wrong. And then you move to conscious incompetence. You know you're doing it wrong, but you don't know how to do it right yet. And then you have conscious competence. So you know how to do it and you're doing it well. And we have to get athletes to unconscious competence. They don't have to think about it, but they can do it well. So that takes a lot of time to retrain your brain, retrain your muscles, retrain your movement system, all that kind of thing, and then be able to apply it to something really fast or reactive or whatever.
So then you start with less load and slowly progress and build up
Mm-hmm.
to the point that they can perform what they need to perform
Yep.
in a sports setting. Very cool. Okay. And like, do you see any difference on rehab times using the MSI versus conventional PT?
Typically, in total time, it may be about the same. It all really depends on what the factors are that you have to address. So some things get better faster. So if it's a very basic movement and they have sufficient strength, flexibility, joint mobility, etc., and then they just need to learn to do it differently, that could go really fast. If we have to wait for a muscle to go through different recruitment patterns and then strengthening and hypertrophy and then develop power, that could take a really long time. So it really depends on what the deficiency is. Quite honestly, sometimes regular physical therapy is much shorter because they just address, does your knee hurt? And once your knee doesn't hurt, okay, you're done. Whereas we might take an extra 2 or 3 months, not seeing them necessarily 2 or 3 times a week, but keeping track of them over a longer period of time to get their movement squared away so that they're actually using their body in the way that they need to, not just, does it hurt? No, okay, good, you're gone.
Mm-hmm. You have the return to activity piece, return to
Mm-hmm.
sport really piece that a lot of times we don't see on PT practices,
Mm-hmm.
right?
Yep.
And then hopefully that helps them long term, not have to come back.
Right.
Okay. Anything else, Jamey, that you want to add for everything that we just talked about that you think it's important to mention?
I think just for the clinicians that might be watching, listening, that uh, being willing to look away from the complaint of the patient. So my ankle hurts, my knee hurts, my shoulder hurts, whatever, to really think about why they're moving the way they do. Most people can learn fairly quickly or kind of intuitively know that someone's not moving the right way, but really be willing to dive into why do they move that way? Do they move that way because it's compensation for trying to keep away from pain? Or do they move that way because they're weak somewhere and their body doesn't have any other choice or whatever? So just getting to that why. That's why we always harp on, patients, let's get to the why of what's going on here. Because if we just address the what, you'll either be back again or you won't perform the way you want to, or you won't notice the compensation and you'll hurt something else or whatever. So just being willing to look away from the area that is garnering all the attention and investigate that more. And for anybody who's an athlete or patient or whatever, seeking out a clinician who understands that, whether they're using the formal MSI system or not, is super important because you'll have a much better understanding of why your body is moving that way, or why you're having pain, or how to get rid of the pain, or how do you move on from there, uh, more so than just, you know, I had lateral elbow pain and they did ultrasound and put some needles in there and gave me some stretches and I'm done. Just why did you have it? So, and sometimes the why is as easy as you just way overdid it. Great, you move fine. You just way overstressed a muscle or a tendon, and therefore you got tendonitis. So, also important to know that.
Yeah. And for the clinicians that want to learn more about that, do you have any resource of information you recommend?
I recommend the Washington University School of Medicine Physical Therapy website. Even if there isn't any continuing ed courses that are happening in the near future, they're really, really personable about getting back to people about where there might be courses or getting them information or whatever. They're really, really great at just conveying that information. I will say the one thing that they're not great about is promoting themselves. So you probably won't see a lot of commercial kinds of continuing ed courses that you can just Google and find somewhere. But with questions about MSI, the faculty at WashU are really, really good at explaining it and helping people get in touch with resources.
Okay, great. And what would be advice that you'd give to a clinician that is starting their careers?
Oh gosh, the ones coming out of school, especially the ones who haven't had MSI as their background, just try to think, kind of like I said, think in that way of movement and why are the people moving the way they are, and then use your tools. And for some students, you just need to have more tools. You need to develop more tools through continuing education or whatever, residency programs or whatever. But having the tools isn't the end game. Knowing how to use the tools you have and having more tools is the end game. So you have more options to help people and you know why you're using certain things, not just, oh, I've got 18 different techniques I can use. I'm just going to use them all and see which one works.
Mm-hmm. Having a system, right? A way that you can assess and treat and follow so you don't get lost on putting all the pieces together. I think that's what's complicated. Sometimes you learn a lot of different techniques, and if you don't follow a system that guides you, you just start trying, okay, let's try this mulligan, this Maitland, this manipulation, this, that, and see what works.
Yeah, and the good and the bad is, let's say you make someone better, but you don't have any idea why. Then the next person who comes in with similar symptoms and it doesn't work, you still don't know why. So if you have that framework of, oh, I did a manipulation here and it worked, I know exactly why, because that particular joint wasn't moving well. But it didn't work over here because that wasn't your issue. Your issue was you had poor motor control. So therefore we didn't need to do the joint mobilization because that wasn't your issue. So from patient to patient over, your career or years and months and decades, that you'll have a better chance of helping more people in a more efficient amount of time. And they appreciate that.
Yeah, being more efficient. If anyone wants to find you or contact you, how they can reach out to you?
I'm fine with emails. My email address is DrGordonPT, so Dr. Gordon PT @gmail.com. And I would recommend, if anybody is listening to your podcast and wants to contact me, just reference that they saw us in our discussion. That way I'll have an idea of where they got the information and can help them more from that way.
Awesome. Jamey, thank you so much for sharing your knowledge and your experience with us. I appreciate it.
Yeah, no problem.